Good evening, everyone. It's a pleasure to welcome you all to another enriching session of GynoScope, a collaborative academic initiative by Dr. Aditya Nimbkar and SIMSOG. GynoScope was envisioned as a platform for young medical minds to connect, learn, and grow together in the field of obstetrics and gynecology. With each session, we bring you a clinical case, presentations, interactive discussions, quizzes, and the ever popular brain benders by Dr. Nimbkar. Today's case on RH negative pregnancy will be presented by Vineet Ramprasad Chandak and Sumedh Rajendra Akarte from Seth GS Medical College and K.E.M Hospital, Mumbai. The presentation will be evaluated on the basis of clinical history, examination, management and understanding of the topic, communication, higher order of thinking. A heartfelt thank you for all the participants for being here today. Thank you for joining us, and we hope you enjoy and engage with the session ahead.
So, hi everyone, Dr. Aditya here. So, thank you for the introduction. Today's case is going to be on RH negative pregnancy. Along with that, I would also want to discuss fetal anemia and fetal hydrops or hydrops fetalis simultaneously. So, Vineet, are you ready? Vineet and Sumedh, are you ready?
Yes, sir. We'll start sharing a screen.
Yeah, sure. All the best. Harini or whoever is organizing, has the auto admit option been turned off? Because I see there are a few people who are awaiting to join yet.
No,
We
sir,
have four slots that are remaining.
it's still very much on.
Okay, fine.
Is my screen visible?
Yeah, it is. You can
Okay.
start.
Yes. Um, Patient 30 is a 32-year-old gravida 2 para 1 living one. She's at 38 weeks plus 1 day of gestation. She's married since 8 years, resident of Ghatkopar, Mumbai. She's a housewife by occupation and is Muslim by religion. She belongs to the low socioeconomic status and she came with chief complaints of pain in the lower abdomen since yesterday. Her last menstrual period was on 22nd of October 2024, and the expected delivery date is 29th of July 2025. She's a registered case at our hospital, that is the K.E.M hospital. Uh, the HOPI, she was apparently all right since 1 day back when she had continuous dull aching, lower abdominal pain, acute in onset, non-progressive, non-radiating, and was not associated with bleeding or leaking per vaginal. There's no history of outside food intake, no history of fever, loose stools, no history of burning micturition, and no history of decreased fetal movements. The history of present pregnancy in her first trimester. This is a spontaneous pregnancy. She noticed a delay of 1 week in her regular periods when she did a UPT, urine pregnancy test, which was positive. Pregnancy was later on confirmed at 8 weeks of gestation by ultrasonography scan. She was started on folic acid and calcium supplementation. Her blood group is A negative, and her husband's blood group is O positive. The indirect Coombs test was done at 11 weeks. There's no history of early morning nausea and vomiting in the first trimester. No history of any other drug intake. No history of radiation exposure. No history of fever or bleeding PV. NTNB scan was done at 11 weeks and was normal. Rest of the first trimester was uneventful. The second in a second trimester, she had 3 antenatal visits. Iron, folic acid, and calcium supplementations were continued. Iron folic acid supplementation was started in the second trimester. Quickening felt at 18 weeks of gestation. 2 doses of tetanus toxin were given at 16 weeks and 20 weeks of gestation, respectively. Blood glucose levels were checked and were normal. There's no history of headache, visual symptoms, or epigastric pain. Anomaly scan done at 20 weeks and was normal. No history of bleeding or leaking PV. In her third trimester, she is admitted for 1 week. She was admitted for 1 week at 28 weeks of gestation for same complaints. However, she doesn't recall the details of the treatment given. Fetal movements were perceived at 12 to 15 for 12 to 15 times a day, and IFA, that is the iron, folic acid, and calcium supplementation was continued. Her indirect Coombs test was done, and it was negative. She received anti-D prophylaxis at 28 weeks of gestation. Growth scan was done at 32 weeks of gestation and was normal. There's no history of leaking or bleeding per vaginal, and she is currently now admitted with us for the same complaints of continuous dull aching, lower abdominal pain. The past obstetric history. Her first child was a male. She born at 2 years after marriage. Birth weight was 2.6 kgs, and he is currently 6 years old. He was delivered at full term by lower segment cesarean section (LSCS), alive, well, and is immunized till date. Mother did receive anti-D prophylaxis post delivery at the time of the first child. Menstrual history. She had her menarche at 14 years of age. The last menstrual period is 22nd of October 2024. She is a known case of polycystic ovarian syndrome, and irregular periods were there for 3 to 4 days of bleeding. She required 2 to 3 pads per day, and it was not associated with pain or passage of clots. Marital history. She's married since 8 years in a non-consanguineous marriage. The past medical history is not significant. There's no history of diabetes mellitus, hypertension, TB or TB contact, asthma, allergy to any medications, and no history of blood transfusion. Personal history. Her bowel and bladder movements are 10 to 15 times per day. Bowel movements are unaltered. Sleep and appetite is unaltered, and she denies any addiction. Diet history. Currently, she is on hospital diet. She before being admitted, she had a sedentary lifestyle, and her calorie intake was 2010 calories. Protein calorie requirement was 2010 calories. Protein requirement was 58 gram. Total calories was 1680 calories, and total proteins consumed were 46 gram, which gives a deficit of 330 calories and 20 grams of protein. Family history is not significant. Over to Sumedh for general examination.
General examination. The patient was examined in a well-lit room with consent in presence of a female attendant and is conscious, cooperative, and is oriented to time, place, and person. She is averagely built with height of 152 centimeters with pre-pregnancy weight being 56 kilograms and current weight being 65 kilograms. Her pre-pregnancy basal metabolic index was calculated as 24.2 kilograms per meter square. Then moving on to her vitals, she was febrile at the time of examination. Her pulse was 82 beats per minute, measured in right radial artery in supine position with normal volume, force, and tension. Her blood pressure was 126 by 72 millimeters of mercury, measured in right arm supine position. Respiratory rate was 18 cycles per minute, thoraco-abdominal breathing. Pallor icterus, clubbing, cyanosis, and lymphadenopathy were absent. She had progressive edema feet, progressive during the day, which relieved on rest. Breast examination, it was fully developed breast, anesthesia 5, and breast engorgement was seen. Now moving on to obstetric examination. Inspection revealed abdomen being uniformly distended, umbilicus was inverted, striae gravitarum was present, and linea nigra is also present. Previous LSCS scar was present 2 centimeters above pubic symphysis, measuring approximately 15 centimeters. No sinuses, dilated veins, or any scars other than LSCS scar. Hernial orifices were absent, and flank fullness was absent. Then palpation, fundal height was revealed to be 36 weeks, and fundal height measured was 34 centimeters, with abdominal circumference being 104 centimeters, and there was no LSCA scar tenderness present. Then Leopold's maneuver. First Leopold's maneuver, fundal grip revealed broad, soft, irregular, non-palatable mass felt, suggestive of fetal buttocks, which is suggestive of breech. Second, umbilical or lateral grip, smooth, uniform, curved resistance felt on right side, suggestive of fetal back. And on the left side, multiple knobs were felt, suggestive of fetal limbs. Third, for Leopold's maneuver or first pelvic grip, smooth, hard, globular, palatable mass is felt, which is suggestive of fetal head. Fourth, or the second pelvic grip confirms the finding of the first pelvic grips, hands converged and head was not engaged. So overall, the Leopold maneuvers infers the lie is longitudinal, presentation is cephalic, fetal head is not engaged yet, and fetal heart rate was 140 beats per minute measured on right spino-umbilical line. Systemic examination, cardiovascular system, both first and second heart sounds were heard. There was no murmurs. Respiratory system auscultation revealed bilateral air entry equal with no adventitious sounds. And central nervous system examination, higher mental functions were normal. Now, coming to the summary of the entire case, 32 years old, 38 weeks plus 1 week pregnant, gravida 2, para 1, living 1, with complaints of dull aching, continuous lower abdominal pain since 1 day, suggestive of threatened labor. Her blood group is A negative and husband's blood group is O positive, having received anti-D prophylaxis in previous pregnancy, post-delivery, and at 28 weeks in current pregnancy prophylactically. On general examination, vitals are stable and no significant findings were noted except progressive edema, which relieved on rest. Obstetric examination infers about a singleton fetus in longitudinal lie, cephalic presentation with fetal heart rate of 140 beats per minute, not in labor. Diagnosis, 32 years old, gravida 2, para 1, living 1, 38 weeks plus 1 day pregnant with A negative blood group, having received anti-D prophylaxis in previous as well as current pregnancy with complaints of lower abdominal pain since 1 day, is a case of Rh negative unsensitized pregnancy with a singleton live fetus in longitudinal lie, cephalic presentation with abdominal pain suggestive of threatened labor, and is admitted for further management.
Great history, Vineet and Sumedh. Kind of flawless. I don't think there was anything that was missing. So could you just go on to your first slide now? Yeah. So in your, could you just switch on the, that's great. Now in the demographic history, do you think there is anything that is significant to your case of Rh negative pregnancy? Anything?
No, sir.
Are you sure there is absolutely nothing that is significant? Sumedh, Vineet?
So, maybe the religion might be one of the factors.
Yeah, religion, yes, factor in definitely. In fact, even more than religion is a factor, your location. These things have pockets. Pockets, by pockets, I mean there are pockets of places which have certain blood groups that are more prominent. Now, a couple of months back, I was in Chhattisgarh, and in the 3 months that I was there, I just saw one case of Rh negative pregnancy, whereas in Mumbai, in our OPDs, we get at least 2 to 3 cases per day. So it has a lot of regional endemicity, I would say, the blood group. So you have taken a history in Mumbai, which happens to be a hotspot, I would say, for Rh negative pregnancies. You'll be getting them quite a lot. Okay. Religion, not really. Religion would be a lot more important when it comes to hemoglobinopathies like sickle cell or beta thalassemia. One important part in your history that you shouldn't be missing is your parity. Your female is previous pregnancy. She has had a previous pregnancy. This is not her primary pregnancy. So the risk of Rh negative isoimmunization may be higher.
Yes.
So that is the important part. Secondly, she is third trimester. You mentioned she is 38 weeks. So we are going to have a discussion about with the patient about her termination. She is already in threatened preterm labor, so it will be spontaneous. But yes, um, by the way, she is admitted at 38 weeks of threatened labor. This is a question that a lot of people have, that a lot of residents have. So I would want you to answer. Do you give or do you terminate these patients at any early gestation than 40 weeks, patients with RH negative?
Sir, ideally, the patients should not be allowed to cross the expected delivery date as the number of weeks of gestation or as the pregnancy increases, the risk of pretermaternal hemorrhage increases. So ideally, they should be terminated around 39 to 40 weeks if it is an uncomplicated, and if it is complicated, termination should be carried at around 37 to 38 weeks.
You mentioned complication. What complication are we expecting here?
So we might be expecting, since not in this case, but in general, we might be expecting complications such as hydrops and fetal anemia.
So if you have a baby with with features of fetal hydrops, when would you terminate it? You mentioned 36 to 37. Your patient has, let's say, at 28 weeks of gestation, it is already having signs of hydrops. What would you do? Would you terminate her?
No, sir, will not terminate it. We'll wait till 34 weeks, and in the meanwhile, we'll evaluate her hematocrit and go on to, if required, go on to carry an intrauterine transfusion.
Very good. Good answer. That's a better answer. Okay. ठीक है. Next slide. So she had this is something that I like. I've always preferred that y'all mentioning about pain in abdomen, bleeding PV, leaking PV, or decreased fetal movements first whenever you're talking about any history of presenting illness, and then you can continue talking about all other differentials. Now, what you have done in your history is very good. It is something that has really impressed me. The fact that you have ruled out all other causes of abdominal pain. A lot of people tend to miss the fact that a pregnant female is still a normal physiological woman, and most of her problems are not going to because of her pregnancy, but because of her being a human itself. So that's a good thing that you have ruled out things like gastroenteritis or urinary tract infection, which is a good thing. So everyone, this is a point to be noted. Whenever you have any case in your exam with abdominal pain, even though it might be obvious and you might already know about the case being a case of something XYZ and her being in labor, always still rule out all other causes of abdominal pain because those are also very important. So history of outside food intake, fever, loose stools technically rules out any any other cause, any simultaneous cause. History of burning micturition. You have mentioned that she has no history of decreased fetal movements. Um, why and how can it be significant in your case?
Sir, decreased fetal movement can be a complication of her, means there might be fetal-maternal hemorrhage, or in general cases, since she is a multigravida, if not in this case, but if she would have been a primary gravida, the head would have been engaged. It also has decreased fetal movements.
Okay. So the biggest cause in your case is going to be if she is not monitored for RH isoimmunization, that then can be an intrauterine fetal demise. So that is going to be your biggest differential in first place if it is going to be decreased fetal movements or absent fetal movements. Otherwise, the fact that you mentioned that she is nearing term, that is very correct. She is already having labor, and hence during labor, because of uterine contractions, she may not be able to perceive fetal movement. That's a good second alternative. Okay. Next slide. Okay, so history of present pregnancy in the first trimester, she noticed a delay of 1 week for which, okay, her husband is O positive and she herself is A negative. Indirect Coombs done at 11 weeks. Okay, fine. So now can you tell me what is fetal maternal hemorrhage?
Sir, Fetal-maternal hemorrhage is when the fetal blood gets spilled into the maternal blood due to any of the reasons in the first, second, or third trimester. Some of the reasons being instrumentalization.
Just mention the first trimester details first. We'll go trimester wise with each slide.
Okay. Yeah. So in the first trimester, there can be ectopic pregnancy. Then there can be missed abortions. There can be spontaneous abortions. Uh, which can lead to fetal maternal hemorrhage. Uh,
Chorionic villi sampling can also be done in first trimester, which can also
Yes, very good. That's a great answer. First trimester towards the end of first trimester. Anything else? Any points that you might be missing? You are correct until now.
ectopic pregnancy.
Already mentioned. Things that you have not yet mentioned. Some alternative type of abortion. You have mentioned missed abortion. Any other type of
Threatened
threatened
abortion as
abortion?
well. Yes.
That's a very important diagnosis. In fact, that is one of the most important differentials in your first trimester. Very good. Anything else? One more thing, one last thing, which is constant across all trimesters. Trauma. If there is any trauma, if there is any injury, that is also abdominal trauma. Not so much in first trimester because the first trimester abdominal trauma is not going to be sustained directly on the uterus, but a possibility, a rare possibility. Okay. And now you mentioned about ectopic pregnancy. We'll be talking about abortions, ectopics, and one more thing that I don't think you mentioned, molar pregnancy.
Yes.
Yes, sir.
In partial
Yeah,
molar, it can be, but in complete
yeah.
molar, yeah. Okay.
Okay, so let us assume that you have a patient. Let's go with the simplest, that is abortion. You have a patient with missed abortion, and she has come to you at 6 weeks of gestation. What do you do next for her? How do you manage her? How do you manage a case with missed abortion, a patient with missed abortion?
Uh, Sir, if it's a case of a missed abortion, the care that has to be taken is after, if she's in this case, if it would have been a missed abortion, we should consider giving her a
No,
anti.
in general, what do you do for missed abortion? You carry out a termination, you do evacuation, right?
Yes.
Once the diagnosis is confirmed. Okay.
Yes.
Then you're going to be doing an evacuation. Evacuation happens to be a surgical procedure.
Yes.
So, for that surgical procedure, you will have to open her os. So, for opening that os, which is the drug that you give?
Mhm. For we can give vaginal progesterone gels to ripen the cervix.
Vagina progesterone gels. How do you open up the os by giving progesterone? In fact, progesterone is given to keep it closed. That's a grossly wrong answer. You cannot be saying that I'm giving progesterone to terminate pregnancy.
The misoprostol.
Yeah, misoprostol. You will be giving out misoprostol, the most important drug that is required to open up the cervical os. So once the cervical os is open, now you have to remember that misoprostol is also going to act on your uterus. And when it acts on the uterus, it is also going to lead to contractions, uterine contractions, which is also why the female perceives pain the moment you start giving her misoprostol. Now, every time there is a contraction, that each contraction is a feto-maternal hemorrhage event. Each and every contraction is going to lead to some amount of feto-maternal hemorrhage. After that, once the cervical os is open, you are going to be doing a curettage or manual vacuum evacuation. Basically, surgical evacuation is going to be carried out, which is going to be a second and a even more important and major event of feto-maternal hemorrhage. So, the reason that you give anti-D to a patient with missed abortion is not the missed abortion, but what you do or what you do for the management of missed abortion, which is giving misoprostol, the first thing, and secondly, giving surgical evacuation or carrying out surgical evacuation for her. Okay, then if not for surgical evacuation, a patient is now coming to you with a scan that is suggestive of complete abortion. What do you do for that patient? For a patient with complete abortion, how do you manage a patient with complete abortion?
Uh, so we'll look for if in case
So we'll look for if there are any retained products that might
No, she has come to you with a scan and your examination also suggestive of complete abortion.
NTD. Then we would give anti-D.
Would you give anti-D to a patient with complete abortion? Vineet, Sumedh?
So we have no idea about it.
See, the two important events that led to me giving anti-D in the first patient who had missed abortion was that she needed misoprostol, and the definition of complete abortion is wherein a female has come to you with the pregnancy completely aborted and the os is also closed and she is not bleeding. So basically, nature has done its work of completely evacuating the uterus. That's it. You will. She tells you no, there was no excessive bleeding, there was just a bit of spotting. You ask her if there was any active pain, काफी pain हुआ क्या? She says no, it was a painless abortion. These two circumstances, if they are ticked, you do not need to give her anti-D unnecessarily. But if she says that yes, there was a lot of bleeding, but now that I've done a scan, there is nothing inside, or there was a lot of pain before I aborted, and then I've aborted, if either one of these is fulfilled, then she becomes a candidate for anti-D. So in complete abortion, technically, you should not be giving it. The only reason you will give it is if there was excessive bleeding wherein she soaked a lot of pads, or if you or if she gives you a history of pain. Pain is basically equivalent to the uterus contracting to expel the concept is. So this is how you would be answering if you are asked about complete abortion. So complete abortion per se will not require anti-D, but if she has any one of these two conditions is when she will require anti-D. Okay.
So
Incomplete
I had a
Yeah,
doubt
ask
in.
me.
So in case of those contractions, wouldn't there be fetal-maternal hemorrhage? The
Yeah, so
uterine.
that is the reason that we are giving anti-D for a female who has complained of abdominal pain.
Okay.
So either one of those two conditions, if they are fulfilled, then you'll be giving her anti-D.
Okay. Yes.
Yeah, so you have to ask her if she says most patients who come to you with complete abortion, they have a history of absolutely no pain and just a bit of spotting. So either the pregnancy has been absorbed by the body or it has been expelled out so early that there was no need for any significant bleeding to happen. In that scenario, you will not do anything. So those are only two exceptional circumstances where a patient has come with complete abortion without any pain or bleeding in whom you will not give it. Otherwise, you will give it if those two conditions are fulfilled. Fine. What do you do for incomplete abortion?
Sir, we'll evaluate whether medical or surgical evacuation has to be done.
Very good.
And then we will evaluate if heavy bleeding is done during surgical evacuation, and then again evaluate for
You
requirement of.
have done a surgical evacuation. The moment you start doing surgical evacuation, fetal-maternal hemorrhage is going to occur.
Yes.
So you have to give her anti-D. And in patients with incomplete abortion, most of these patients come to you with a history of already having bled a lot. Because of the RPOC inside that is highly richly vascular, they have already bled a lot. And let alone that, the moment you're going to give her misoprostol for complete medical abortion or surgical evacuation, it fulfills one of the two criterias. Then she again becomes a candidate for anti-D. Okay?
Yes.
Okay. Last, threatened abortion. Do you give anti-D or not?
Yes, sir, we give in because the risk of alloimmunization is approximately 4 to 7% in threatened abortions.
Very good. That's a good answer. The fact that you stated a percentage, remember, even your examiner, including me, wouldn't know of these percentages. So if you're going to say it so confidently, that's a great thing to answer. And yes, absolutely, as you mentioned, that perfectly, as you mentioned, that the patient is going to have a significant risk of threatened abortion or fetal-maternal hemorrhage. Threatened abortion is itself wherein a female is not aborted, there is a good viable pregnancy inside, but she is bleeding, probably spotting, or she is having some pain. In that scenario, you will give her anti-D. Okay. You gave her anti-D today. She's a case of, let's say, 9 weeks threatened abortion. After 2 weeks, she comes back to you and she says she is having a bit of spotting and pain again. What do you do?
So this time we will have to again evaluate for if abortion has occurred or not. Secondly, we do not need to give anti-D as half-life of anti-D is around 16 to 24 days, and
Brilliant answer.
its effects last for about 12 weeks.
Excellent answer. That's a great answer. Could you tell me where did you read this though?
Uh, Sir, I have read it in Sharmila Babu and Arias textbook.
Excellent answer. This is something that I'm going to come to towards the later part of this session today, the half-life of anti-D. That's an amazing answer and thoroughly impressive. So, the action of anti-D stays for around 12 weeks, but to be on the safer side, if during pregnancy there are two events of fetal-maternal hemorrhage that are more than 6 weeks apart, then we repeat the dose of anti-D. If they are within 6 weeks, you do not repeat them. So um, in your case, it is just 3 weeks, as I mentioned, as in the scenario that I gave. So there won't be any need for anti-D prophylaxis. Very good. But still, if a patient is very anxious and she has read a lot on the internet, probably she is some doctor who knows a lot about anti-D, and she says कि 9 weeks पे मेरे को हुआ था, अभी 12 weeks पे फिर से हो रहा है मुझे bleeding. So please give me, I can afford anti-D. So is there any test, any particular test that you can do to reassure her that your fetal-maternal hemorrhage is not significant?
So antibody levels can be done.
Antibody levels, rather than antibody, anything better?
Titers.
No. Antibody is going to be when the isoimmunization has occurred, which is a later event. What I want to know is if fetal-maternal hemorrhage has occurred. Fetal-maternal hemorrhage होता है उसके काफी time बाद, takes several months or even years for isoimmunization to happen. So how do you know about fetal-maternal hemorrhage?
So we can do acid elution test or clear Betke test.
Very good. KB test. That's the answer that I'm looking for. Now that we have mentioned about KB test anyway, could you just tell me how was it done?
So basically, means we have to take the maternal blood sample, and then we have to make a smear. And basically, fetal hemoglobin is resistant to the acid elution, whereas the mother's RBCs are not. So when we make a smear, the mother's RBCs are seen as ghosted RBCs, whereas red colored or pink colored RBCs are seen as fetal RBCs. And accordingly to that, we quantitate the fetal bleed as number of fetal cells, and per 1000 maternal cells multiplied by 5000. It's the formula for quantitating the bleed.
That is a flawless answer again. Thoroughly impressive, amazing. So to put it simply, as he mentioned, KB test or the Clio Betke test, the best thing about KB test is that you can do it on a bedside level. All you need to do is you need to add some acid, dilute acid, and you have to add it to a peripheral smear of the mother's blood. Now, fetal hemoglobin, HbF, is resistant to acids, whereas adult hemoglobin, that is HbA, is not resistant. So when you put that acid, all the maternal RBCs are going to lose their hemoglobin. It is going to get denatured. Hemoglobin is a protein after all. So protein is going to get denatured by the acid. But what will remain is the cell membrane. The cell membrane of the RBCs are going to remain. So the cell membrane without the hemoglobin, it is going to look like a transparent cell membrane, and that is called as a ghost cell. It is literally going to look like a ghost. Whereas the fetal RBCs are going to be intact and they'll be seen as bright red RBCs. So you calculate the percentage of fetal RBCs on that smear, and using a formula that is directly given on the internet, perinatology.com पे दिया गया है, उसमें you just have to enter those values and you will get the total amount of fetal-maternal hemorrhage that has happened. So what is significant fetal-maternal hemorrhage that should, what do I say, that
Greater than
should
1 ml.
greater than?
0.1 ml.
Very good. So greater than 0.1 ml. So once you give anti-D, how much of fetal-maternal hemorrhage is going to be covered for?
The normal dose that we give, that is 300 microgram, covers for 30 ml of fetal blood and 15 ml of fetal RBCs.
Very good. The reason is that your normal adult hematocrit is around 30-35 during pregnancy, whereas your fetal hematocrit is going to be around 50 to 60. So depending on that is why we consider that 30 ml of fetal blood will contain 15 ml of fetal RBCs by taking approximately 50% as the hematocrit of the fetus. Good. In first trimester, what is the dose that you'll be giving though?
So less than 12 weeks, we give 50 microgram, and for any of the procedures or missed abortion or anything, and greater than 12 weeks, we give 300 microgram.
Okay, great. So now that we have spoken about all this, um, there's a patient who is highly educated and she comes and tells you that I am RH negative. I know that. I know also that my husband is RH positive. But I also know the fact that my baby can be both RH negative or RH positive. So I do not want to unnecessarily take an injection which may not be required. So could you tell me if I really require to take an anti-D? Could you just tell me
Oh,
if I can check for my fetal blood group?
yes, we can check like cell-free fetal DNA can be used to check the genotype of the fetus and whether he's RHD positive or RHD negative. And depending on that, we can decide further.
Oh, so he or she. So you want to be caught in a
No,
PCP and T
so we
by
can
doing sex
also
determination.
check for whether the husband he is homozygous or heterozygous for the RH factor RHD.
Good. So in the era before NIPT, or what we also call as cell-free DNA, cell-free DNA is what we test. The test name is NIPT, which we usually do for looking for trisomies and all chromosomal aneuploidies. That test, before the advent of it, we used to do the paternal genotype. So once the paternal genotype was done, we would know whether the father is homozygous or heterozygous. Then we would also check the mother's homozygosity or heterozygosity. And after that, we would be able to know whether the fetus may be or may not be positive or not. But again, it was just an estimation. But now, in today's world, rather than doing genotyping, which is much more expensive, we can do a cheaper test of NIPT and determine the fetal blood group. So technically, knowing the parental homozygosity or zygosity, heterozygosity is no longer required because you have NIPT that is going to make everything cheaper than the test for father and mother individually and then determining whether the baby is positive or not. So just an NIPT is going to give you an answer. As you mentioned, cell-free DNA check karenge, you would get to know whether the baby is positive or not. And if it is negative, then you do not need to give anti-D. Fine. So could you go on to the, Acha, you have mentioned about ICT. What is ICT and how is it done? Could you briefly tell me about it?
So basically, ICT is indirect Coombs test, which has to be done on the maternal. We have to take maternal serum and we have to add RH, the RBCs which are RH positive, and then we have to add anti-human immunoglobulin. So if agglutination happens, the ICT test is positive.
Okay. Um, Let us assume that you have a patient who is RH negative. Her husband is also RH negative. But there is some resident, first year resident who didn't know कि husband का भी blood group check करना है, and you end up checking the mother's ICT and it comes out to be positive. What do you do next?
So we check for titers.
Okay, you check the titers, they come out to be 1:32.
So then we have to means I'm not really sure about this answer, but we have to check if there was any assisted reproductive technology was done and if there was any.
No, she says that it is just my husband and there is no ART either that was done.
Then we have to repeat the test. It might be a false positive.
You repeated it from the best lab, you repeated it from the government of India's ICMR lab, and it turns out to be the same.
Not sure, sir.
You are thinking like an obstetrician or from a individual subject's point of view. Do not do that. Think like a clinician. Remember, ICT is not the test that you read for the first time in obstetrics. You read about it in your pathology, then you again read about it in your medicine and Harrison's, and then you read about it in obstetrics. ICT is a very non-specific test. It is only indicative of some antibody that is present against some against some RBC antigen in the mother. Remember, you mentioned that in ICT we insert anti-human globulin. You do not insert anti-D that is specific. So
Yes.
that globulin can bind to any other antibody. So the point that needs to be noted here is if the mother has some history of transfusion or has some history of hemolytic anemia or is currently having hemolytic anemia, then also her ICT is going to come out to be positive. So if you're getting ICT positive in such scenarios wherein you are not sure whether it is because of RH isoimmunization, then you get something called as immunotyping, wherein you do typing or basically you just determine towards which antigen has this antibody bound. And that is how you would know whether this is anything related to the fetus in first place. It just may not be a fetal problem. It may be a maternal problem that you're looking at. Remember that whenever you give any blood transfusion, assume karo in the first trimester, the mother had severe anemia because of any reason, and she was given a transfusion. We only check for major antigens whenever we are creating a blood bag. There might be several minor antigens that may go missing, which you do not check because they are not significant, because they do not lead to any transfusion reaction. And one of those minor antibodies or minor antigens may have led to the positive ICT ka response that has come in your patient. In that scenario, your ICT immunotyping, your antibody immunotyping is going to help you. So do not always think as an obstetrician that it is only because of the fetus. Think of it from other ways and also then look towards finding whether she has hemolytic anemia and whether it is significant or not. Got it?
Yes, sir.
Yes, sir.
Okay. To everyone in the audience, I hope you all also got this point. Immunotyping is the name of the test that you do it. Very few labs do it. Very highly equipped labs only do it. So you may not find it at all the labs. Okay. So ICT was done at 11 weeks and ICT was negative, right? You have not
Yes.
mentioned.
Yes, it was negative.
It was okay. It was negative. Next slide. 3 antenatal visits, quickening felt, headache. Okay, no history of headache. Everything is normal. Okay. Next scan. Next slide. Admitted for 1 week at 28 weeks of gestation for same complaints. However, she doesn't recall the details of the treatment given. Fetal movements perceived 12 to 15 times a day. NTD was negative. Okay. So now let us assume that you got the first ICT that you did at 12 weeks or 11 weeks as positive. What do you do next?
So we will then evaluate for titers as well as the husband's blood group, and
Okay,
then
good.
if the titers are greater than 1:16, then we have to manage as a case of RH alloimmunization, and if the titers are less than 1:16, we have to keep her under observation by doing repeated titers every 4 weeks.
Is that 1:16, 1:8 a very firm, matlab, is it like a fixed value that you have, the critical titer?
No, sir. It differs from lab to lab.
Okay, good. So the critical titer is going to be lab specific. You have to ask the lab what is their critical titer and then you have to monitor it. If it is less than critical titer, after how many days or weeks do you call the female back to check her titers?
4 weeks.
4 weeks. Okay, and you do 4 weekly monitoring of her titers.
Yes.
Once the titers cross the critical range, you never measure them again. You only do MCA PSV monitoring. Correct? How
Yes.
frequently do you monitor the MCA PSV?
Sir, every 2 weeks.
Every 2 weeks. Okay, great. And at what weeks do you start monitoring this MCA PSV minimum?
So minimum is 16 to 18 weeks, but usually started after 20 weeks.
Okay, why do you say it is 16 to 18 weeks? Is there any particular reason for that?
Not sure, sir.
So the fetal reticuloendothelial system matures at around 16 to 18 weeks. And hence, your antibodies from the mother that are bounding or that are binding to the fetal RBCs are not going to directly destroy them. They are going to take it to the fetal spleen and then it is going to be destroyed there. This requires maturation of your reticuloendothelial system in the body, and that happens by 16 to 18 weeks. So you usually start this MCA-PSV monitoring after 18 to 20 weeks only. You do not start it before that because it is going to be falsely negative. And even if you are going to be able to start it before that, if you're going to do it, even if you get a value that is suggestive of fetal anemia, you cannot do transfusion at such an early gestation anyway. You will anyway have to abort the pregnancy because there are changes of anemia so early in the pregnancy. Hence, it is futile to check it before 16 to 18 weeks. So most people start it after 20 weeks. Also, because in private practice, doing a Doppler kind of can be an expensive thing to be doing it every 2 weeks. If you're going to spend 2,500, 3,000 rupees every 2 weeks, you better just delay starting it and make it only when it is required. So the reticuloendothelial system is the reason behind that. Okay, so you're monitoring it every 2 weekly. And what exactly do you monitor?
So the peak systolic velocity in the middle cerebral artery is to be monitored.
Okay, so what is the reason that you monitor? What is the reason that you monitor the peak systolic velocity?
So because in case of fetal anemia, there is high cardiac output and it leads to greater blood supply to the brain. And as the brain is an
No,
oxygen demanding organ, it is one of the first organs where we see increased velocity of blood flow, amount of blood.
no, that is not the answer.
So
Something else. You're very close.
brain sparing effect.
Brain sparing effect. Oh, brain sparing effect is something that happens when there is hypoxia, fetal hypoxia. So fetal hypoxia is not occurring in this case. There's some other reason why we are looking at MCA PSV. There's a reason why we look at MCA, there's a reason why we look at PSV. Two reasons basically. Why?
Uh, Not sure, sir, about the alternative reason.
So your baby is having anemia, hemolytic anemia. So your RBCs are dying off. Basically, they have been destroyed. So you have a hemodiluted blood sample. A diluted blood sample that is less viscous is going to have higher velocity. It is like water and Fevicol. Water is going to have a higher flow velocity than Fevicol will, which is basically the difference in the viscosity. Hence, hemolytic anemia increases the blood velocity because of the reduced viscosity of the blood. That is the reason you look at PSV, that is peak systolic velocity. The reason you look at middle cerebral artery is that it is a very constant and easily detectable vessel in the brain. Also, there is no difficulty in making a, what do I say? You can end up erring between anterior and posterior cerebral artery. You can interchange between them. But because middle cerebral artery goes lateral to them, it is the only artery that goes in that direction, and hence it is easily detectable by everyone. Hence, every chart, every algorithm has been made with respect to the middle cerebral artery. Also, it lies on the lateral wing of the sphenoid. So it's a artery that is lying static over a bony prominence of the head. Hence, very easy for me to be doing a Doppler of that and measuring the peak systolic velocity. That is why we measure MCA PSV. Two reasons. Got it?
Yes, sir.
Okay. So what are we measuring? We are measuring MOM. What is MOM?
Sir,
Multiples of median
yes,
unit.
Multiples of median. Okay. What is my cutoff?
1.5, greater than 1.5 is to take further steps.
Okay. Why are we not just measuring MCA PSV? Why are we measuring the MOM of MCA PSV?
Not sure about it, sir. The why it's the unit, the MOM, we are not sure about that.
So as your gestational age increases, all your vessels in your body are getting bigger. The diameter is also increasing. So as the diameter is increasing, the flow velocity that is there at 20 weeks is not going to be the same at 30 weeks. So you need something that is going to make them constant, which is why the statistical method of calling it multiples of median has been introduced, so that you do not rely on a single value, because your MCA PSV is going to be different for the same level of fetal anemia at 20 weeks than at 30 weeks. It is going to be completely different. So to unify it, we have decided to introduce MOM. In fact, in every single fetal monitoring, be it your dual marker, quadruple marker, everything, you have MOMs. The reason being, at every gestation, with each increasing day, the fetal parameters change, and you cannot have different fetal parameters for every day of pregnancy, which is why a statistical method was required, and hence MOM method is very useful for measuring anything in the fetuses. Got it?
Yes, sir.
Yes, sir.
Okay. So you have measured MCA PSV, your cutoff is 1.5. Your first value comes out as, let's say, 1.45 at 24 weeks. What do you do?
So we have to the 1 point as according to the critical title. Supposing the critical title is 1:16, so 1:4 is not significant. We have to just
No, no, not 1:4. I'm saying 1.45 is your MOM.
oh, sorry.
So we will continue monitoring, repeat it every 2 weekly. And at 32 weeks, we have to start with fetal monitoring, that is NST and biophysical scores and uterine artery Dopplers. And in meanwhile, if it crosses 1.5, we will go on to the algorithm to evaluate the period of gestation and the further steps.
Okay. So see, the thing is, we do say that less than 1.5 you do not monitor, more than 1.5 you monitor, or you do chordosynthesis. But remember that 1.4 to 1.5 is that gray zone. So what I was doing every 2 weeks, I was doing MCA PSC monitoring every 2 weeks. That is applicable till a MOM of 1.4. Between 1.4 to 1.5, I'll do it weekly. And once 1.5 is crossed, is when you would start doing the thing that you said. Algorithmic approach is going to be taken up. So what is that algorithmic approach once it crosses 1.5?
So once it crosses 1.5, we evaluate what is the period of gestation. If it is less than 34 weeks, we have to do a chordosynthesis and evaluate for fetal hematocrit. If it is more than 34 weeks, we give one dose of betamethasone or dexamethasone and go for a cesarean section. No, go for
Okay.
a cesarean
A
section.
cesarean, we just deliver. We can even deliver vaginally. We just plan termination after 34 weeks if the MM was anywhere above 1.5. Okay. What if it is less than that? You measure the hematocrit. What is your cutoff hematocrit for transfusing?
So less than 15, less than 30% is the cutoff which we get in the after chordosynthesis in the fetal blood.
Okay, very good. So 30%. At what, could you just tell me at what percentage does fetal hydrop set in?
15% of the hematocrit.
Yeah, 10 to 15%. Less than that, it starts setting in. Good. Okay, so 30% के नीचे हो गया, you have to transfuse. Now, how do you transfuse?
So there is either we can go by intravascular route, intraperitoneal route, or intracardiac route. Basically, there are three routes
Very good.
of transfusing the blood. Then it is basically double volume exchange transfusion. We transfuse with O negative blood group, which has to be irradiated. We have to check it whether it has any anti-KEL antibodies. Then it should be cytomegalovirus negative, and it should be transfused at around 160 ml per kg. And the O negative blood group should have been extracted, and it should be around only 5 days old.
Okay. Do you use umbilical vein or umbilical artery?
We
Or
use
you
the
have to do
umbilical vein,
intravascular?
sir. We use the umbilical vein. We can use the where it attaches to the placenta, where it enters the placenta. That is where we insert the needle and start the transfusion.
Can you tell me why do we use a placental end?
Sir, it is more stable.
Very good. It is a static end. Okay. But if you're going to be doing this, the fetus may keep on moving and the cord will keep on moving. Do you do anything for that?
So we administer actually to decrease fetal movement. We use
What do you
vecuronium,
administer?
vecuronium at
Vecuronium, yeah.
0.1 mg per kg or atracurium.
Very good. So you give intramuscular vecuronium or atracurium. Good. Mostly vecuronium is used. It is given in the deltoid or in the gluteus of the baby, and then you start transfusing. Okay. Now this is a fetal medicine concept. If you're able to answer this, nothing like that. If you're not able to answer this, your marks don't get affected. If you do answer, your marks definitely increase. Could you tell me which vessel, and it is not the MCA PSV is your hint, which is that vessel that we monitor before giving the transfusion to ensure that the fetal heart is not going to be overloaded with blood?
The uterine artery.
No.
So the umbilical artery.
No, the answer has been given by Uzma. That is correct. The answer is ductus venosus. So why ductus venosus? See, ductus venosus is that vessel that connects the umbilical vein to the IVC and then to the heart. So whenever there is hydrops that is about to set in or is setting in, your heart has undergone bad changes. The heart is not any longer compliant. So when your heart is not compliant, if you transfuse anything, the heart is not going to be able to tolerate it. So if your heart is not going to be able to tolerate it and it is going to fail anyway, you have to give multiple transfusions of small amounts rather than giving one transfusion of a bigger amount. So in that case, to decide whether what to do, we do ductus venosus Doppler. In ductus venosus Doppler, if there is reduced flow or if there is reversal, then it would indicate that my heart's compliance is completely gone. My right ventricle is completely fibrosed, or I would say is just not compliant enough and is giving back pressure changes into my IVC and eventually into my ductus venosus. And hence, a non-compliant heart will not tolerate blood transfusion in entirety in one go. You will require multiple transfusions. So ductus venosus is the most important vessel that you check before giving transfusion. Once you give transfusion, how do you monitor?
So we have to monitor it by first is we have to target the target hematocrit. We have to see whether it has been achieved or not. So the target hematocrit for less than 24
Would
weeks.
you every single time insert a needle inside the abdomen, check the hematocrit? Is there any non-invasive way?
Peak systolic velocity. Middle
Very
cell.
good. Very good. Peak systolic velocity. So what is your new peak systolic velocity threshold after the transfusion is done?
1.69.
Very good. 1.7. Very good answer. That is impressive. So you keep the new threshold as 1.7 because if you keep it again as 1.5, you will never have it as normal. The baby is already having anemia. So you cannot have the normal threshold of 1.5. So it is going to be 1.7. And hence, if the subsequent values fall by fall below 1.7 is when you would give transfusions. Okay. One thing that you have to understand is with each passing day, the hematocrit falls by 1%. So if, for example, your current hematocrit was 25 before transfusion and after transfusion, you did a CBC immediately and it became, let's say 50, then it will take around 20 days, which is around 3 weeks for your hematocrit to again fall below 30%. So approximately 1% se per day girta hai hematocrit. And hence that is how you can also determine whether I have to give a repeat transfusion or not. Just an average estimation. Okay. We spoke a lot about giving intrauterine transfusion. Let us just come back to our topic. You at 28 weeks have given her anti-D. Could you tell me what is the mechanism of action of anti-D?
So the anti-D is a immunoglobulin, which when there is feto-maternal hemorrhage and the fetal RBCs cross the placenta and enter the maternal blood, which does not have those Rh antigens, and these antibodies, if already present in the maternal blood, will bind with these fetal RBCs and mask those antigens, and also clear the fetal RBCs, and hence there will be no sensitization of the mother's immune system.
Very good. That's a good answer. So basically, anti-D ka primary action is to coat the fetal RBCs in the maternal blood and prevent immunization. A secondary action that is nowadays coming out is also to inactivate the maternal antibodies that were formed against the fetal RBCs. So that is a second action that is now being studied as well, because it is not just an anti-antigen injection, it is an anti-antibody. So its primary action is supposed to be the one where it inhibits antibodies, but it was not being proven yet. It was being just said कि वो antigens को coat कर रहा है, but no. The newer studies also say that it even coats the antibodies and binds against it. So fetal RBCs and maternal antibodies, it coats both of them and it protects the fetus. Okay. So we have already spoken about anti-D. You give one dose. Now it is about the question that I had asked on the group yesterday. You have given a dose at 28 weeks. Why do you give the next dose directly after delivery? And is it important to give that dose at 28 weeks?
So we have to give the dose at 28 weeks basically because there might be some cases of feto-maternal hemorrhage which are undetected occurring before means after 28 weeks because during 28 to 40 weeks there is increased risk of isoimmunization and also
Very good. The highest risk during pregnancy for fetal-maternal hemorrhage is in the third trimester. So you have to protect that third trimester, because until 28 weeks, the fetal-maternal hemorrhage was only going to be less than 0.1 ml. But as we mentioned, 0.1 ml is the significant fetal-maternal hemorrhage and uske upar hone wala hai in the third trimester, that is after 28 weeks, which is why the dose at 28 weeks is very important. Could you tell me though, ये 0.1 जो value है, क्यों आया है existence में? Why is it that all patients with all patients don't get isoimmunized? Why only a few patients with Rh negative pregnancies with Rh positive fetuses get isoimmunized?
Sir, first might be the the female might be a non-responder. Then the amount of the feto means the amount of blood loss might also be less, and sometimes ABO incompatibility also plays a role. Means if the fetus and the mother is having different blood groups, the mother's immune system will clear out the fetal RBCs or means which is having other ABO blood group before the anti-RH action starts.
Very good. But primary patient में ये क्यों होगा? Primary patient में तो ABO incompatibility that you mentioned is not going to play a part, or will it play a part?
Sir, I have an answer. There is something called as grandmother's theory, which might
No,
play.
the grandmother's theory or the grandmother's paradox, whatever you call it, is not important in this case. Why is ABO incompatibility a stronger antigen antibody response than RH?
So because it takes place at a faster rate and earlier than the
Why does it occur at a faster rate?
Because antibodies to it are already present in the maternal serum.
Very good, very good. Why are they present?
because they are from birth, like the mother has them from birth.
Okay, very good. One more answer is that a lot of antigens that come from microorganisms, bacteria and viruses, mimic A, B antigens in the body. So basically, all these bacterias, all these viruses are always going to ensure that you have antibodies for A and B in the body already. Also, if your mother is O positive or O negative, whatever, she already has anti-A and anti-B in her body. And those antibodies, since they are in her for a long time, they are all IgG. And IgG is going to cross placenta even in first pregnancy, which is why ABO incompatibility can affect the first pregnancy as well. And it is also much stronger response. It is also going to be a much stronger immunogenic action than your RH isoimmunization. Okay. Coming back to the causes why RH isoimmunization doesn't occur in all, you have mentioned all of them correctly. It has a low immunogenicity. The mother can be a non-responder. And lastly, it is very important to note that these antigens may often get destroyed before they cause any action, which is why RH isoimmunization is not going to lead to action in everyone. Okay. So, okay, fine. Next slide. Okay, so had you confirmed what is the blood group of the first male child?
No, sir, we didn't ask for that.
Yeah, always ask. Very important, because what if it turns out that the first baby was negative? So the mother may not have been eventually given an anti-D as well. It may not be required for her. So always ask about it. Uh, Regarding anti-D, you were talking something about the half-life. Could you just repeat it for me again?
So the half-life of anti-D is about 16 to 24 days, but its effects last for around 12 weeks.
Okay, so because it is lasting for 12 weeks, it is covering your entire third trimester from 28 to 40 weeks. But by the time you have delivered, that is around 40 weeks, the fetal hemorrhage that occurs during delivery is so large that it is coming towards the fag end of the action of your anti-D that was given at 28 weeks, which is why it requires that the female be given an anti-D after delivery as well. Okay, which is the test that you do after the birth of the baby to determine whether the mother has to be given anti-D or not?
So we evaluate for direct Coombs test in the fetal blood as well as the fetus blood group has to be determined.
Okay, very good. Any other test that you do for the baby?
Photosynthesis.
Record क्यों करेगा when you have the baby in front of you?
No, sir. According to the algorithm, I think only these two are conducted. Rest of the tests,
Which is the first test that you mentioned?
the direct Coombs test.
Yeah, correct. Sorry. So yeah, direct Coombs test is the one that you will do. If the direct Coombs test is positive, do you give vaccine to the mother? Because in pregnancy, if the ICT is positive, you do not give the vaccine. But if the DCT is positive, do you give the mother
No, it's the other way
anti-D?
around. It's the other way around for DCT.
What is it then?
If the DCT is negative, and if the baby's the blood group is Rh positive, then we give another dose of anti-D to the mother.
Okay, so there is a school of thought which I do not align with. The school of thought is whenever the DCT is positive, the mother already in her body and the baby has already received the antibodies. So the school of thought is that the mother now already has so many antibodies that they have crossed and they have entered the baby's circulation. So they say that once this isoimmunization has happened, you do not give anti-D to the mother. The parallel school of thought and the school of thought that I'll align with is that if the mother is positive, that is fine. She may have antibodies, but also this delivery event has given her even more fetal hemorrhage and she has even more fetal RBCs in her body. Now, if I do not remove or neutralize these RBCs, her immune response in the next pregnancy is only going to get stronger and bigger. And hence, to neutralize these new RBCs that have entered her during delivery, I will be giving her anti-D. Also, because of the secondary action of anti-D to inhibit the antibodies and to reduce them, is also why, irrespective of the baby's DCT status, I would want to give the mother anti-D injection if the baby is blood group positive. Okay.
Yes.
Yes, sir.
Okay. Um, if your mother is undergoing tubal ligation, do you give her anti-D?
Yes, sir. We give that.
Why?
So because in future she might get pregnant through IVF or IUI, uh,
Okay.
and hence to protect that pregnancy, we need to give her an anti-D today.
Very good. So tubal ligation is not the end of it. The female may have a change of partners in future because of some reason. She might have death of the current baby for which she again wants to conceive after a few years and she wants tubal ligation reversal or tuboplasty. At that point, it will be too late to give the vaccine, to give anti-D, which is why, irrespective of the fact that she has undergone a tubal ligation or not, I will definitely give her in this pregnancy anti-D. Okay. Now that we were anyway talking about the tubes, let us come to another topic that I left behind, ectopic pregnancy. Do you give anti-D to patients with ectopic pregnancy?
Yes, sir, we do give that.
Okay. Do you give it to all the patients who have ectopic pregnancy?
I think we give it only for ruptured ectopic pregnancies.
Okay. Sumedh, any other thoughts on this?
So abdominal ectopics we need to give. Maybe.
Okay. Your line of thought was correct until 4 or 5 years ago, and it's still considered correct in a lot of hospitals and by a lot of clinicians that you give it only in cases with ruptured ectopic, because then there is going to be a frank fetal-maternal hemorrhage. Peritoneum में fetal RBCs सब गिरेंगे maternal peritoneum में, and there is going to be isoimmunization. But now the second school of thought that has come in, and a lot of even the latest grain top guidelines says, is that medical management ho या expectant management ho या surgical management ho, the region of ectopic is highly vascular. And because of that vascularity of the tube, the tubal vascularity or the cervical, जहाँ पे भी ectopic हो, the risk of fetal-maternal hemorrhage is there in all type of ectopic, irrespective of its outcome, whether it ruptures or it doesn't, whether you give her medical management or you don't. Irrespective of that, there are chances of fetal-maternal hemorrhage, and hence, for every single ectopic pregnancy, now you give anti-D. The evidence is limited on medical management. It is strongly in favor of surgical management to give anti-D, but still you give the benefit of doubt to that female, more so because she has already lost a tube or she already has an ectopic, so her next pregnancy is technically a precious one for her. I would not want to give her a bad outcome from Rh negative point of view, which is why I will be giving it for all ectopic pregnancies. What about molar pregnancy?
Sir, earlier it was thought that complete molar there is no need to give, as there is no formation of the fetus. But now it is being thought that RBC production starts. So irrespective of partial mole or complete mole, we have to give anti.
Are you sure that in complete mole there is an RBC that is formed? Those are just vesicles.
Sir, I've read that there is no formation. Earlier, it was thought that in complete mole there is no need to give anti-D and there is need to give in partial mole. But now there is some evidence that RBC production also starts in complete mole.
Okay. The other reason I would rather suggest, see, in partial mole, you have paternal and maternal antigen both. In complete mole, you do not have maternal antigen. So it is only the paternal antigen that is present, and you require both the antigens to be present or both the genomes to be present to create an RBC. The reason we still give it in complete as well as partial mole is that the only way you can differentiate between a complete and a partial mole is when you have a histopathology form that is available with you, a histopathological report that is available. And a histopathological report takes 2 to 3 days bare minimum to come to you. And by the time the report is available in government hospitals, it can even take 10 to 15 days. In that scenario, she would already be isoimmunized if it turns out that on histopathology, she was a partial mole. Remember, your way of diagnosing it on histopathology is to look at the type of karyotype, or you have to do the karyotype to determine, and you have to also look at P53 as a factor to determine whether it is partial or complete. So your ultrasound is not the way you diagnose partial or complete. You can only suspect partial or complete on ultrasound. The only way to confirm any type of mole is on histopathology and immunohistochemistry. And hence, you will be giving the benefit of doubt again to the female and giving it in both the patients. Remember that there can be a debate in your exam if you are mentioning the RBC reason, because it takes both the genomes for RBCs to form. And the core basis of complete mole is that there is no maternal antigen present at all. There is no maternal genome at all that is present. It is just an ovum without any maternal content inside it. And hence, the RBCs can be a debatable point. But what is not debatable is the point that the report is going to take a longer time, and your histopathology report, by the time it comes, it can be too late to give her immunization. And hence, you give anti-D to her any which way if there is a molar pregnancy. Got it?
Yes, sir.
Okay. Um, so next question. Okay, the next slide. By the way, in the comments, I have posted the feedback form. Kindly, everyone, kindly fill the feedback form. It is going to help us take note of whatever your issues are, and we would love knowing about whether you're liking the presenters and the questions as well. Yeah. So menarche and everything, not significant. Okay. Next slide. Next slide. No history of blood transfusion. Yeah, that is a significant point. Okay. Next. Okay, fine. Next. Okay, fine. Um, so we are done with the RH isoimmunization part. A little bit on fetal hydrops and fetal anemia. Could you just tell me what are the other causes in which you can have fetal anemia?
Yes, sir. Fetal anemia can also there can be a non-immune causes also, um,
Okay.
such as there can be chromosomal anomalies, or there can be
You are talking about hydrops. I am asking about fetal anemia.
fetal anemia. It can happen in case if there is twins and twin-to-twin transfusion syndrome.
Yes, very good. Good. Monochorionic complication. What else?
Then there can be umbilical vein thrombosis.
Oh, bapre. Okay, wow. What else? Give me a few simpler causes, more common.
Maternal anemia,
What?
severe maternal anemia.
No. That is the point that you have answered. I am going to answer it in the anemia in pregnancy event, but now that you have anyway said that, um, who was it? Vineet. Vineet, you answered that, right? Would you want to rethink on this part that fetal anemia can be caused by maternal anemia? Is that possible?
So that was answered by Sumedh, but I don't agree with it. The reason is that because there is an active transport of iron, and the maternal stores are enough to sustain the fetus and not make it anemic. Like,
Very good. So your placenta has something called as ferroportin, and that
yes.
ferroportin is going to ensure that even if the mother is depleted of all her nutrients and especially iron, the baby is never going to be depleted of it. The baby is always going to receive ample amount of iron or be it any other nutrient. So even if the mother has an HB of 3 or 4, in the baby, the hemoglobin is still going to be 15 or 16, which is normal for that baby. So maternal anemia is not going to lead to fetal anemia unless the mother has hemolytic anemia and there is some IgG that is crossing the placenta and leading to fetal anemia as well. Coming back to fetal anemia, give me one of the commonest causes of fetal anemia.
Torch infections and
Torch
parvovirus.
infections, exactly. Parvovirus B19, very important infection. That is what I was looking for. Okay, anything metabolic?
So G6PD deficiency.
A G6PD, very good. Metabolic disorders or G6PD, what else?
So thyrotoxicosis.
Okay. Anything that is affecting your liver, because in your fetus, the main hematopoietic organs are your liver and spleen. So anything that affects your liver and spleen is going to lead to that. So any of your glycogen or lysosomal storage disorders, Gaucher's and all, usme bhi you are going to have fetal anemia. So all the metabolic diseases is going to have this problem of fetal anemia. Okay. Talking about fetal hydrops, what are the types of fetal hydrops?
So immune and non-immune.
Immune and non-immune. Okay. This is a type of RH isoimmunization is a type of.
Immune cause of hydrops.
Okay. What are the causes of non-immune hydrops?
So there can be cardiac anomalies in the fetus. Then there can be hematological problems such as beta thalassemia and G6PD deficiency. There can be also
Okay.
chromosomal causes such as trisomy, triploidy, or aneuploidy. And
Very
then
good.
there can be, as I mentioned, placental and umbilical causes such as twin-to-twin transfusion syndrome, umbilical vein thrombosis, and chorangioma.
Okay. Great. What is the definition of fetal hydrops?
Sir, basically, fetal hydrops is fetal anemia, hematocrit less than 15, and fetal hemoglobin less than 4 gram%. It will, then, sir, I know the findings, but I'm not sure if it is the definition or not.
Very simple. It is a USG finding which suggests of
Sure.
presence of
Sir,
edema in 2 or more
yes, sir, yes, I
cavities.
know that.
Yeah. So 2 or more cavities. So which are those 4 cavities where you have to look for? Or
Uh,
4 places?
Pericardial effusion, pleural effusion, ascites, and subcutaneous edema with skin or scar
Very good.
body.
Anasarca. Great. Great. So that is your cause of hydrops. So remember, your non-immune hydrops can be because of each and every system. Every single anomaly, every single systemic anomaly can lead to fetal hydrops. Could you quickly tell me the pathophysiology of fetal hydrops? Why does fetal hydrops happen?
So,
Fetal
so,
hydrops technically is cardiac failure, heart failure of the fetus. So why should that happen?
so heart failure leads to hypoxia in the fetus as well as metabolic acidosis. That
Okay.
leads to liver cell death as well as liver failure, which leads to hypoproteinemia, hypoalbuminemia, which then leads to the edema, like edema, fluid collection at various sites, pleural effusion, pericardial effusion, subcutaneous edema, etc.
E- Excellent. That's an excellent cause. So you have mentioned the cardiac cause of hydrops fetalis. Non-cardiac causes, things like torch infection. Any idea how will they cause fetal anemia? Fetal hydrops.
So they may cause endothelial damage, which leads to fluid exudation and then further leads to fetal hydrops.
Okay, not really. So see, anything in your system that is going to affect your liver and spleen, something like torch infection or parvovirus B19. Let us look at torch infection. It leads to hepatosplenomegaly because of hepatosplenic failure, or something like Gaucher's disease, wherein all your hepatocytes are damaged. So the same thing as you mentioned, that once your hepatocytes are damaged, your hypoproteinemia is so definitely occurring, but also your hematopoietic organs are being damaged. So if your hematopoietic organs are being damaged, your heart is going to have cardiac overload because it is going to be hyperdynamic circulation. Less RBCs, the heart has to pump more. And hence, also because of hypoproteinemia plus cardiac failure because of cardiac overload, is why fetal hydrops is going to happen. So you have to link everything to why the heart is failing, because fetal hydrops is technically heart failure of the fetus. That's it. Got it?
Yes, sir.
Okay, fine. We are about to end, by the way. So a few more last questions. Can you tell me any alternate use of anti-D?
Other than in causes of fetal-maternal hemorrhage.
Yeah, any other use of anti-D?
So it can be used during prior to external cephalic version or internal podalic version. Then
Okay, but that is again fetal-maternal hemorrhage. Think over it. By the way, everyone, I have pinned the feedback form. Kindly fill it for the attendance as well as the certificate. By the way, the certificates are going to be given at the end of 12 sessions, not before that. So yeah, please fill them. Your feedback really helps us. I love reading those feedbacks. So yeah, any alternate use of anti-D apart from fetal-maternal hemorrhage, apart from a pregnant female? Do you use it in a non-pregnant female or in a male?
Not sure, sir.
So it is a form of an immunoglobulin. So in places where you need IVIG, but it is not available, or if you have to give immunoglobulin therapy for anything like Guillain-Barré syndrome, or as a post-exposure prophylaxis for hepatitis B, in that scenario, maybe even for something like ITP, immune thrombocytopenic purpura, wherever there are antibodies in your body which you have to suppress, in that scenario, also anti-D can be given. It's a very rare use of it, and it is very unlikely that a place has plenty of anti-D, but it doesn't have IVIG. But one of its use can be for this reason as well, because it is something, though it is specific to anti-D, the D antigen, but still it can still act as an independent isolated IG, that is immunoglobulin, and suppress the antibodies that are there, which is also what explains its secondary action, that is suppression or binding of the immunoglobulins. So that is the alternate use of anti-D. Last question, what is the maximum dose that you can give in a day?
sir, anti-D maximum
5 vials of 300 microgram.
Okay, 5 vials of 300 microgram is the intramuscular dose.
Yes.
That is total of 1500 microgram. And if your patient has any cause because of which you cannot give an IM injection like thrombocytopenia, punic purpura, thrombocytopenia, or coagulation disorder, then you give IV. What is the maximum dose of IV?
Sir, I don't know. As far as I have read, it was written that we do not get IV because anaphylaxis can be there.
Sir, The IV has to be prepared by means it has to be specially prepared. We know about that, but we don't know about the maximum dose in IV.
It has to be specially prepared. You give it under hydrocortisone cover so that anaphylaxis does not occur, and the maximum dose that you can give is going to be एक मोमेंट पे 600 दे सकते हो, ऐसे दिन में 8 hours अपार्ट 3 बार दे सकते हो. So the total of 1800 microgram can be given in a single day. But if there is any need to give एक दिन में 1500 या 1800 का डोज, इतना ज्यादा अगर फीटोमेटल हेमरेज हो रहा है, ऑनगोइंग है, then you would rather want to just deliver that baby and make it survive outside rather than inside. Okay. Any other earlier ways that you know of before we had ultrasound? How did you monitor fetal anemia?
Amniocentesis.
Amniocentesis to do what?
The amniocentesis was done, and a Lily's chart was used. We used to evaluate the
Lily's graph, that is basically we plot the optical density at 450 nanometers of the bilirubin and versus the period of gestation from 27 weeks to 40 weeks of period of gestation. And according to that, it has zones, zone 1, zone 2, and zone 3, and accordingly managed.
Very good. So basically, you look at the bilirubin because there is hemolysis, there is going to be increased bilirubin inside your amniotic fluid. So that is what you determine. What happens if there is excessive bilirubin in a baby that is just delivered because of hemolysis?
Uh, because of excessive, since now the umbilical cord has been cut and there is no connection with the mother, the bilirubin starts to accumulate and there is liver dysfunction, so there would be jaundice in the baby.
connectors
Okay,
as
jaundice and
well.
kernicterus. Yeah. So kernicterus doesn't occur inside a fetus because the placenta does the work of fetal liver to to conjugate the bilirubin and remove it from the body and to metabolize it basically. So until it is there inside the inside the uterus, the placenta is doing the work and is helping the fetus survive. But once it is out, the fetal liver gets overwhelmed with the excessive amount of unconjugated bilirubin that is coming its way, and hence that leads to your increased chances of kernicterus. Okay, last question. Any maternal problems that can arise because of ISO immunization?
Due to placentomegaly, there can be PIH and polyhydramnios.
Very
Post
good. PIH, polyhydramnios.
hemorrhage.
Very good. A last higher order thinking question. If there is fetal hydrops and it is followed by maternal severe preeclampsia, what is the syndrome called as?
So can you repeat?
There is fetal hydrops and this is followed by maternal severe preeclampsia. What is this syndrome called as?
Yeah, the mother's. No, it's mirror syndrome.
Mirror syndrome.
Mirror syndrome. Very good. Excellent, Viva. And you have answered all the questions really well. Highly impressive. One of the better Vivas that I've taken lately. Excellent, Vineet and Sumedh. Amazing. Well done. So that is it from today's session. And I hope you all liked it. Kindly fill the feedback form. I'll just solve all the questions. There were several that were going on. A few questions I'll ask Vineet as well that have been asked by the audience. Vineet and Sumedh both try to answer them. Um, One of the questions, a very simple question, is why is the first RH negative pregnancy usually unaffected, but subsequent pregnancies are at a higher risk? Simply, just quickly answer this one. Why is the
So
first pregnancy safe?
because in the first pregnancy, during the primary exposure, the antibody would be formed IgM, which cannot cross placenta. Also, it would take lot of amount of time, minimum 12 to 16 weeks to occur. So it wouldn't happen, and IgG would be formed much later.
Very good. So IgM will not cross the placenta because it's a large molecule. It's a pentamer. It is not going to cross your placenta, but IgG will. Next question is with a female. Okay, we have already answered that. What if a female doesn't receive anti-D in the next 72 hours after delivery? What would you do next, Vineet?
We will wait up till maximum up till 28 days because that's the maximum time. We can give it up to 28 days.
Very good. So you can still give it, the best action is in the first 72 hours, lesser action till 10 days, and the least action till 28 days, no action after 28 days. Okay. If there is no history of past blood transfusion, can we skip antenatal anti-D? One question is, if there is no history of blood transfusion, this is primary gravida, first pregnancy, can we skip antenatal anti-D?
No, we
No.
cannot skip.
No, we cannot skip.
We cannot skip. Very good. Because third trimester is when you will have fetal-maternal hemorrhage, irrespective of any event. You will have it invariably. Okay. Next question is, mm, so, whoa, what a question. Sir, what happens if anti-D is given to the baby instead of the mother? What will happen?
Medical legal case.
Medical legal implications, definitely. I'll have to shut the hospital. I'll be lucky enough to be working as a CMO after that. And if I'm not lucky enough, then I might have to find a parallel career in hospitality or something. MBA करना पड़ेगा. But बेबी को एंटीडी अगर दोगे तो क्या होगा? जितना डोज दे रहे हो उससे बेबी का सिर्फ 30 ml न्यूट्रलाइज होगा. बेबी के अंदर they say that how do you calculate the total amount of blood volume in a baby? It is 80 into the body weight of the baby. So if your baby is, let's say, of 3 kgs, then your baby will have 80 into 3, that is 250 ml of blood in the body. So 240 में से अगर तुमने 30 ml कर दिया तो 1/8, which is around 12.5% of the blood is going to get neutralized. It is going to be broken down. Temporarily उसको थोड़ा bilirubin, hyperbilirubinemia में ऐसा बैठेगा, and the baby will recover from it. So it wouldn't kill the baby, but it will definitely kill your career. Mirror syndrome. Okay, then ideal gap between two injection anti-Ds, if required, it is 6 weeks, minimum of 6 weeks, unless you do a KB test and it shows that the fetal-maternal hemorrhage is more than 30 ml. Then you have to give yet another dose before 6 weeks as well. If the father is RH positive and the mother is RH negative, what are the percentage of the chance will be RH positive? It all depends on what is the zygosity of the father and the mother. So जैसे हम लोग वो पाइसम सटाइवम के लिए जो पी रहता था उसके लिए हम करते थे छोटा टी बड़ा टी, छोटा टी बड़ा टी, वैसा कैपिटल डी छोटा डी करने का है और देखने का है व्हाट आर द चांसेस ऑफ द बेबी बीइंग. इट इज अ प्रॉपर मेंडेलियन चार्ट बनाना है तुम लोग को. If the 28-day window is also missed, what can be done for a safe subsequent pregnancy? See, what you can do is actually nothing. You will have to just monitor the mother in the next pregnancy, do her ICT during pregnancy, and then monitor her. One of the more expensive ways that you can opt for is doing immunophoresis, but then immunophoresis for merely, not immunophoresis, plasmapheresis. Plasmapheresis karna to remove just the antibody doesn't make sense. It is expensive, very invasive. So you would just wait upon for next pregnancy and then monitor her due diligently. You cannot do anything to reduce the chances now. You can just monitor and prevent fetal anemia from occurring. That's it. So that's it from today's session. Thank you so much, everyone. I hope you all benefited from this discussion. I don't believe 1.5 hours का discussion RH negative पे हो सकता था. We have tried to tackle all the questions. Thank you so much. If the patient had 2 previous abortions, she hadn't taken anti-D, what should we do? You have to consider something like ICU immunized and you have to just do our ICT. That's it. ICT monitoring जैसे करते हैं वैसे ही करना है और कुछ नहीं. Same thing that you do in normal pregnancies, nothing different. So thank you so much, everyone. Thank you, Vineet. Thank you, Sumedh. It was an excellent, one of the best presentations that I have had, one of the better vivas that I've taken. I hope everyone benefited from this. So thank you so much, SIMSOG. And we have put the feedback form. Kindly fill it and let us know your feedback on today's session. Thank you. Good night. We'll meet again on Monday night at 10 p.m. Yes, by the way, we have shifted our session from to Monday. So kindly attend it. Yeah. Chalo. Thank you. Good night.